A very good morning to all of you. I'm Arosh Harisanayaka, President, Ceylon College of Physicians. Welcome to the month of June and the month of neurology. As you all know, the CCP has divided the months of the year to different themes. And for the month of June, our theme is neurology. We've had several activities connected to neurology. So far, we had a college lecture early part of June. Then we had in our cutting edge series where we get an overseas expert to speak on recent advances. We had a very erudite lecture from Professor Henry Ma about a week ago. And so that's two items out of the way. And today we have a very, very important segment, which is the specialty update, where we will have 4 top neurologists in this country speaking to us about 4 very important topics. And then, of course, we will conclude the month a little later with the neurology quiz. And you know that neurology quiz offers you a good challenge to take part in and also offers some small prizes as well. So that's so if you all listen to today's lectures, you could get the neurology quiz sorted out quite easily, I'm certain, because most of the questions will be based on today's presentations. And for this morning, we have 4 top neurologists in this country, Darshana Sirisena, Kishara Gunratna, Manjula Caldera, and Sajita Veerasinghe. I very warmly welcome all 4 presenters for this morning on behalf of the CCP. And I will introduce the first speaker. Thereafter, the Q&A questions and Q&A and the rest of the presentations will be conducted by Dr. Kumarangi, who is the Secretary of the Association of Sri Lankan Neurologists. And if by any chance you missed any of the ones that I spoke about, for instance, Professor Henry Ma's lecture, all of them are available on the CCP YouTube channel. You could go back and listen to that as well. And these lectures in about 24 hours will be uploaded to the CCP YouTube channel. So if you wish to look at them again, or if you want to encourage someone else to look at this, you could do that. I mean, all of these are available on the CCP YouTube channel. Right. So it is my great pleasure and privilege to introduce my friend and colleague, Dr. Darshana Sirisena. He is the president of the Association of Sri Lankan Neurologists, and he is honoring the CCP by actually delivering the first talk himself. And he is going to speak to us about the approach to a patient with a tremor. Thank you, Darshana. Thank you for being here, and thank you for bringing your full team here. And thank you very much for being part of us. And I hope you will continue to play a major role in CCP neurology activities. Over to you, Darshana. All of you have a good day.
Thank you, Arosha. And at the outset, I should thank the CCP on behalf of the Association of Sri Lankan Neurologists for inviting us to get joined in their program, being a sister organization. I especially should thank Professor Uday Ranawaka and Dr. Kumarangi Vitanage, who was coordinating on behalf of the Association of Neurologists with the CCP. And I should also thank from the ASN for the other resource persons, that is Kishara, Manjula, and Sajita. So without much delay, shall we go ahead with my talk? Okay, so the talk today is approach to a patient with tremor. So as you know, when it comes to the neurology, movement disorders was one of the major parts of it, right? So when it comes to the movement disorders is one of the subdisciplines of neurology. So there are 2 conditions that I mentioned, hypokinetic and hyper. As name implies, hypo is the less movements, and hyperkinetic is the other extreme, where there's excess of movement. So when it comes to here, the hyperkinetic movement, there are about maybe closer to 100 conditions, but what is clinically important is there are about 5 conditions which we come across in day-to-day practice. Tremor is one of them. So the important thing is these conditions can be differentiated from each other clinically. So if it comes to the tremor, it's involuntary. For that matter, almost all hyperkinetic conditions are involuntary, so there should not be any help. But the most important clinical feature that helps tremor from other conditions like chorea, dystonia, or tics or myoclonus, it's rhythm. So it's out of these conditions, the tremor has the most rhythm and very predictable. And it's an oscillatory movement around a part of the body. So I'll go to the next slide and show you the video, what I mentioned. So just concentrate on patient's right hand. So you can see there is a very rhythmic movement around the wrist, which is oscillatory. So this is basically a tremor. If you want, I'll show you once more. If it is a chorea, it's not. It's very random movement, very unpredictable. So that is how you differentiate. So when it comes to the introduction, tremor is one of the commonest, not the commonest movement disorder we come across. It involves mostly the upper extremity, but for that matter, it can involve any part of the body. The impact it has when it is severe, resulting in severe disability of the activities of daily living, so that their occupation, social lives, ultimately social embarrassment and withdrawal from the society even. So that is the impact the patient might have with the commonest, the tremor disorder. So the important is, as there are different kinds of tremor with numerous underlying etiologies, the important thing is tremor classification. The process of tremor classification, evaluation is of very utmost importance, very critical importance to establish the correct diagnosis and initiate the most appropriate treatment. If you can't diagnose the thing, you can't initiate appropriate management. So the important thing, classify them, then come for a diagnosis and then treat them. Sorry for the slide. So I'm going to base my talk next 15 to 20 minutes on this article. This is what we call this was actually from the International Parkinson's and Movement Disorders Task Force, which was led by Professor Kailash Bhatia from Queen's Square. He is no stranger to us. He has spoken in many of our events in the Neurology Association. So with his leadership, majority of the people in the world got together and made a statement. How do you classify tremor? In fact, this is a revision. The first one came in 1998. This revision came about 5 years back. So according to this classification, we have two main axes. This is not something new. We know when we evaluate patients, how we do when a patient comes to clinical presentation, we evaluate their clinical features by the history, examination, and then if necessary, we do certain investigations. Once we lump them, we go for etiology. So same applies here, nothing much, but it's in a more methodical way. So as you mentioned, when the clinical features are their disease, it forms to a syndrome. Finally, it goes, when the syndrome is formed, we try to find one or more etiologies on that. So according to this, axis 1 is clinical features, which has 4 pillars, as you could see in this slide. The historical features, which we take from the history. Then the tremor characteristics. We observe the tremor and certain characteristics has to be identified. I'll go by next few slides. Then the associated signs, which could be neurological or systemic, or there are certain soft signs, which is not that clinically important. And if all these are completed, if necessary, you can go for additional laboratory tests. So this is the clinical evaluation of a patient with tremor. History, examination, the characteristic of the tremor in the part of the examination, and what other associated type, which could be systemic or neurological, or both even for that matter, and lab test if necessary. So when it comes to the clinical features, medication history, medical histories of prime import. What are the things you have to know? The age of onset, the family history, the temporal evolution, very, very important. How the patient start with the acute onset? It is started very insidiously. How does it progress up now? Very important, the evolution, temporal evolution. And important, you have to note any exposure to drugs or toxin. These parts are very important when you are evaluating a patient with tremor. Then the characteristics of tremor is next one, which could be what part of the body is involved, activation condition, and the frequency if you could determine. Then the associated side, already I dealt on that, and the laboratory test if necessary. I'll go one by one. So when it comes to the age of onset, these are the ages, but the most important I have to tell, though, you know that in this country there is no proper medical recording system, but in most of the other countries they do. So what is important here, sometimes certain conditions have 2 peaks. For an example, association tremor patients might have a peak around their late teens or early adulthood, but they recover, they comes spontaneous recovery with or without peaks. With spontaneous recovery, sometimes with treatment, and they recur again. So it's very important to note that the patient has. Unfortunately, as you know, our patients can't remember what happened over last few months also, so we can't be what happened here. So it's very important, if a patient comes, carefully document in the patient's records. So then the other important is the anatomical distribution. You have to tell these patients as the focal one. What does it mean by focal? Only single part of the body is involved. That is maybe the one limb, the voice, or maybe the jaw, or the neck and head. So there is one part. What is segmental involvement is 2 contiguous body parts in the upper or lower limbs. Common example is the neck and the upper limbs, or both upper limbs, or for that matter. Then hemitremor, as the name implies, it's one part of the body. Generalized is all. So I'm not going to dwell on orthostatic tremor. That is very, very rare condition. The next most important, I'm now, if I come back to this, is what I'm going for the axis one, each pillar, right? The activation condition is of critical importance. Actually, this hasn't changed from the 1998 classification. So it still remains the same. So activation of tremor is this one. So I'm going to buy again one by one. So when a patient comes with tremor, there are two activation conditions, very simple. One is rest, the other one is action. Rest is when the part of the body is completely supported against gravity. The commonest example, if you keep the patient as a tremor, you ask the patient to keep the hand on the patient's legs or the leg. So the gravity is eliminated. Action is during voluntary contraction of the muscles, or the patient has the outstretched hand to do certain actions. If the patient's tremor comes with that, so it's called an action tremor. Action could be further subdivided into three: the postural, the kinetic, and isometric. Out of these, the two important things are the postural and the kinetic thing. The isometric is very, very rare. The postural ones, as the name implies, maintaining a posture against gravity. It is simple. Ask the patient, if the patient has a hand tremor, ask the patient to outstretch the hands and see what happens. If the patient has a tremor in the tongue, ask the protrude the tongue out, right? Kinetic is occurring during active movements. So the kinetic is further divided into three things again. What is simple kinetic? Which is simple kinetic means the intensity of the tremor remains same throughout the action, right? Which is the opposite of goal-directed, or what we call as intention. As you know, as you see, the goal-directed is the intention or the amplitude worsens towards reaching the target. The task specific, as the name implies, it's during specific tasks when the patient is writing or doing something like that. So this cartoon or this slide very clearly show all the tremors which we can come across. So the important thing is with the history and examination, try to put them into one of these cages. So rest tremor, as you know, the clinical pearl I want to give you today is when it comes to patient's rest tremor, until otherwise proven, it's one of the Parkinsonian syndromes. So that you can take this message, I think I have done my part of the job, because we do miss a lot of Parkinson's patients at early stage. So almost always the patient's tremor component is rest. It's think about Parkinsonian. But having said it though, sometimes you might confuse if the patient has a Parkinson's disease or ET. Why? Sometimes the late, because the patient with the ET sometimes have both components, action or the postural as well as the rest. This vice versa also true. The Parkinson's patient is vice versa. But how do you differentiate? The important thing is the amplitude of the tremor in PD almost always diminishes or even abolishes for that matter, at least even transiently during goal-directed. Ask the patient to do some activity from that part of the body. It either diminishes or completely abolishes. Other thing is it increases when a patient is put on a little bit of a stretch, which could be either physical or mental. How do you put in a physical stress? If the patient has a tremor on the left hand, ask the patient to do certain maneuvers or certain actions on the opposite hand. The patient's tremor gets worsens. The other thing, you ask the patient to put a little bit of a mental stress. Ask the patient to name the days of the week backwards. The tremor worsens, which is not in the case of ET. It does not subside during voluntary movement. So keeping this point in your head. So then comes the action tremor, as mentioned. Action tremor is voluntarily maintaining a position against gravity, which I already mentioned. So voluntary movements could be, as I mentioned, kinetic. I have already explained this, so I'm not going to think. Simple kinetic, as I mentioned. Tremor roughly the same throughout the movement. Intensity is getting worse towards the latter, right? Then the other mentioned the task specific, which is peculiar, which is specific for certain tasks. So then comes the physical examination part. Now we have finished the history and the thing. When it comes to physical examination, there are two tremor conditions: isolated tremor syndrome, a combined tremor syndrome. What does it mean by isolated tremor syndrome? The name, as it implies, not associated with any other additional clinical feature. Either they could be systemic or neurological. The patient's only feature is tremor. That's all. That's what I want to mention, isolated tremors. Others may be combined with tremor syndromes. In these patients, the tremor may be associated with one or more systemic or neurological features. I'll just put an example here. If you come across a patient with bilateral hand tremor, when you examine the patient's pulse rate is 110, right? Patient have exophthalmos. You know, this is a combined tremor syndrome. Then if you continue further in the physical examination, you have to look for other neurological signs. What are those? If a patient comes with rest tremor, always think about other features of Parkinson's, like bradykinesia, rigidity. And always, if the patient has a head tremor, look the patient whether the patient has dystonia. I'll just explain in a few videos in the future, in the next few slides. The patient has some abnormal positioning of the part of the body which involves the tremor. Or sometimes you could see even myoclonus like so, which comes. And other systemic finds are if the patient, young patient is coming tremor, and when you examine, the patient has hepatosplenomegaly, and you go and the patient has cave rings, you know where you are heading for, right? That's called other systemic sign. And a patient comes, you see exophthalmos, the pulse rate is very high. So then you know what you are in, like thyrotoxicosis. So you always have to see when the patient has tremor and what additional clinical features are there. Then on top of that, you could lump all these together. So these are tremor syndromes, but I go by one, right? These are the things. So when it comes to now, I have finished the axis 1, which is the history, clinical examination, then the activation conditions, and finally, if necessary, the lab investigation, which I didn't dwell on that because it is not necessary in most instances, I would say, except for diagnosis of thyrotoxicosis or something like that. Then comes the next step is in this axis is the etiological classification. We know that etiology is always lumped to either genetic, acquired, or if you can't find, we call it as acquired. So now I'm coming to one of the more common conditions, or I'd say the commonest tremor becomes the essential tremor. This is the definition of essential tremor, which is very important to know. Essential tremor is an isolated tremor syndrome. That means, what do you mean by isolated tremor syndrome? No other clinical features, no other systemic or neurological signs of bilateral upper limb action. Action is posture, right? So isolated tremor syndrome is both upper limbs, and the duration is very important for more than 3 years. That is very important when differentiating with certain other similar conditions. Important thing is you could have a tremor of the other part of the body, maybe the voice, maybe the head, all over. But important feature here in differentiating is the patient should have isolated tremor syndrome of both limbs, both upper limbs, sorry. So, and should be, as I very clearly mentioned, in the absence of other neurological signs such as dystonia, ataxia, and Parkinson. Now, in fact, out of this slide, there is a thing called ET plus had been developed. For example, if you diagnose ET, and later patient might come with some other features which may be relating to Parkinson's, which happens always, right? So ET plus has been, but for your sake, I don't think you need to go to that level. So other thing is the positive family history, which is noted about at least minimum of 50% essential tremor patients have some sort of family history, as a family history. The important thing is most of you know that there is an improvement with small dose of alcohol, but it is not been in the new classification. The response to alcohol doesn't come as a diagnostic criteria. So the next one is what is more differential diagnosis in the essential tremor, the enhanced physiological tremor. I'm sure this all we have experienced, even I'm experienced while doing this lecture now, I'm sure all of you, right? So what it is the symptomatic upper extremity action tremor that is potentially reversible if the cause is eliminated. For example, you are stressed out, if you can take the stress out, if the exam is over, then the stress is out, the tremor is relieved, like that. So if the patient has thyrotoxicosis, you treat it, the patient's conditions get better or eliminated. So that is why the symptomatic upper extremity action tremor that is potentially reversible if the cause is eliminated. So this should be the bilateral upper limbs, triggered by variety of reversible conditions which I mentioned, anxiety, the fatigue, hypothyroidism, and different drugs. The confirmed when specific axis 2 etiology is found. So you have to found specific etiology, maybe the drugs, maybe thyrotoxicosis, some other things, and tremor should be normalized when the cause is excluded. The commonest differential diagnosis ET, but the most important thing is that is why the duration comes into place. ET, the symptom should be more than 3 years. Then comes the isolated task and position tremors. Isolated task and position, as the name implies, it comes with a specific task. The commonest is the primary writer's tremor, or musician's tremor, or piano's tremor, like that. And most important, this should be sometimes differentiated by the dystonia, which is the writer's cramp should be differentiated from primary writer's tremor, which is writer's cramp is a form of focal dystonia. Then I'll show you some videos. If you can see, this is a primary writer's tremor. See, the patient could not write it at all. When the patient starts writing, the patients get a tremor. This is a primary writer's tremor. How do you differentiate from the writer's cramp? Writer's cramp doesn't start from initially, we'll keep the patient writing. Then the dystonic tremor with additional signs that we call the tremor. Dystonic tremor, as the name implies, tremor associated with dystonia. Dystonia is, the abnormal positioning of a part of the body due to abnormal sustained positioning of a part of the body due to co-activation of the agonist and antagonist muscle. So dystonic tremor, so the simple thing, you have to diagnose the part of the body which is tremulous has dystonia also, very simple, that is right. So one of the clinical features which will help for this is what we call as a gestalt antagonist, or what we call as a sensory trick. The patient, if you ask the patient, is there any maneuver you do to come out of this one? The patient might come say, if I touched my chin, the patient might am much better. So that's called sensory trick. But sometimes there is a called tremor associated with tremor. You have to be careful about these terms that I am referring. Tremor associated with dystonia is patient has dystonia in one part of the body, the tremor is on the other part of the body. Patient has a tremor in the left hand, patient has a dystonia in the neck. So that is not dystonic tremor, that is a tremor associated with dystonia. So if you can see, even without playing this video, you can see the patient's neck in an abnormal sustained posture. See what happens, right? Okay, so you can see the very rhythmic movement in a dystonic part of the body. So dystonic tremor. See what the patient does now, right? Patient keeps his hands on the back of this neck. The patient's in. So this is called gestalt antagonist of sensory trick. Right. Next one is a cerebellar tremor. Cerebellar tremor is this is usually, as you mentioned, it's an intention tremor when the patient's the part of the body reaches the target. The common as example finger nose test, when the patient hand reaches the tip of the nose, that is getting worse. I'll show you a video. Actually, this is the worst nightmare a neurologist can have, because it is very, very difficult to treat either pharmacologically or even for that matter, neither pharmacology by that matter or the surgical intervention. Very, very difficult tremor to treat. So see this patient. You can see this patient has a very mild right hand tremor in the action tremor or postural. See, the left hand is perfectly all right there, but see what happens in the thing. The amplitude and the goes up when reaching the target. So these are typical cerebellar intention tremor. Then the drug-induced tremor, wide variety of pharmacological agents, right? If you go across Google through, you can see hundreds and hundreds of medications which is responsible for drug-induced tremor. What is the key message I want to give? This tremor coincides with the introduction of a medication, or when the patient already on a drug and the dose is increased, dose is escalated, the tremor gets occur, or even the tremor is mild and gets worse. So it's a non-progressive, very temporary, related to the introduction or the increase of the dosage. So the important thing is, commonest culprits are the salbutamol, the beta agonist, though we don't use orally at the moment, but still it's used in the peripheries and other things. For example, sodium valproate is common thing, lithium carbonate, amiodarone, certain medications. So that's why in the history, you always refer to patients' drug and toxin history. So this is a patient whom I had during perinatal time, the patient who was an epileptic patient, uncontrolled seizures. I increased the valproate from 200 BT to 400 twice. So this is what patient came up with. So the relationship should be established to either to introduction of the drug or escalation of the drug. So finally, I'm going to touch little on psychogenic tremor. Psychogenic tremor can occur as a manifestation of underlying neurology, the psychiatric condition. It could be somatoform, malingering, or whatever. The diagnosis, how do you make the diagnosis? That is the key. And at the beginning, I'm telling, never jump into diagnosis of psychogenic tremor until otherwise you exclude most other causes. Don't get fooled by this. Is the last thing you have to consider. How do you diagnose? The issue is very unusual phenomenology. As you know, last 15 or 20 minutes, I explained certain characteristics in certain things. But in psychogenics, this doesn't fit into any of such. Right? The onset may be very abrupt, as well as the patient might completely better on the next day. That is so. Another thing has been consistency tremor. Importantly, you can challenge the patient with the placebo and the patient responses. And the same as the patient distract for certain things. For example, the patient mentally or physically, the patient tremor gets better or completely alleviated. So the important message I want to give slide, the psychogenic tremor should be diagnosed by the neurologist or for that matter, physician, but not by psychiatrist. But if there is an underlying conditions, psychiatric conditions we evaluated that had to be managed. So keep in mind. So this is a patient. I think this patient I saw in Badul about 10 years ago. She is a 22 weeks POA. Sorry. So just see the characteristics of the patient. You can see the right hand is tremulous. See the intensity changes from one place, the amplitude changes from 1 second to the other, right? It's not keeping with neither of ones we explained so far. Now the patient's in the posture, it completely goes off. When I distract, it's calm, goes off. And now with a minute, the patient again remains that I need to shake. So again, the patient shaking come up, see how the amplitude goes up, right? Yeah, so amplitude again goes up as well as the frequency, right? So this doesn't fit into any of the tremor syndromes which I described earlier, right? Now it comes again in this posture also, doesn't fit into any, right? So I'm kind of final stage. The most important summary, the clinical assessment. That is the beauty of neurology. I'm showing each specialty should be the beauty. The clinical assessment plays the key role in managing, diagnosing of tremor syndromes, right? This is the most commonly used method. When necessary, you can couple with investigation if you suspect thyrotoxicosis and other things for the tremor diagnosis, except in orthostatic tremor. I didn't mention about that, it's a rare condition. You don't need any other investigation. It's clinical judgment. But the important thing, a combination of clinical evaluation, at times you might have to couple it with investigations, then you may have to make a come to a diagnosis ultimately, which will lead to the correct management. So thank you very much. If there is any question, I could answer.
Thank you very much, Dr. Darshana, for simplifying the facts on tremor evaluation. Just a couple of questions. Now, you talk about many aspects in evaluating a tremor. So out of all that, so you talk about the age of onset, distribution, posture. Out of all that, is there like just one or two that you could highlight as being the most important when somebody comes with a tremor?
I would say part of the body is most important, right? And the other thing is the activation condition, the rest and the whether it's in the action. Other important thing is just one feature, onset is very important. That is the three key features we want to put around. The part of the body, right? The second thing is the activation condition and the onset.
Right. Another question. Now, if an elderly patient presents with a hand tremor and a head tremor together, hand tremor together with a head tremor, what are the differentials in such a condition?
Yeah, as I mentioned, you need to evaluate the patient and put the clinical signs. For example, if a hand and the upper limb and the neck is involved, various possibilities, right? For example, essential tremor you need to be considered being the commonest but the important thing is that both hands should be involved if diagnosed as ET. Another thing is dystonic tremor, yes, because the segmental, yes, that is one possibility. And even sometimes, depending on the activation condition, rest and the things, even you need to consider Parkinsonism as well, right? So if elderly comes, ET have to be considered. Other things for that, you have to have the bilateral hands involvement. Dystonic tremor have to be considered. Third thing, dystonic or tremosive dystonia, and depending on the activation condition, you need to consider Parkinson's as well. I would say those three are 1, 2, 3 for me.
Okay, thanks. Just one last question. How do we differentiate essential tremor from drug-induced tremor, tremors or physiological tremor?
I gave the answer, right? In my talk, duration. So essential tremor, there should be 3 years. So drug-induced tremor, I don't think it should go 3 years until, if not diagnosed. That is a mistake from our side. The duration, right? Okay. And the drug-induced tremor definitely has very clear relationship with the introduction of the drug or escalating the dose.
Right. So thank you very much, Dr. Darshana, once again, talking to us on evaluation of a patient with a tremor. So with that, we'll move on to the second talk. So next we have Dr. Kishara Gunaratna, who is a senior lecturer and a consultant neurologist from Faculty of Medicine, University of Moratuwa. So he's going to talk to us today on evaluation of epilepsy. Over to you, Dr. Kishara.
Thank you very much, Kumarangi. I hope my slides are seen. Kumarangi, can you all see the slides?
Yeah, I can see the slides, yes.
All right, okay, right. At the outset, I'd like to thank the CCP and the ASN for giving me this opportunity to speak to you on evaluation of epilepsy. This is by no means a comprehensive lecture. This is just an overview of what you might have to do when you encounter a patient with suspected epilepsy. Right. So let's start with a case history. Sorry. Okay, so this is a 22-year-old medical student who attends the neurology clinic with her friend for evaluation of a paroxysmal event. She had attended a ward class and was standing for 2 hours, after which she had experienced tunnel vision and blurred vision. And she also remembers feeling hot at the time. She then abruptly lost consciousness. Her friend who witnessed the episode said she felt the ground stiff and she had jerking of her right arm followed by her left. She lost continence to urine. She recovered within a few seconds and was lucid during this period, albeit a bit embarrassed. So when inquiring into her past, she tells the doctor that she has had episodes in which she would experience a feeling of fear with butterflies in her tummy, and then she would lose track of time for a few minutes. She further explains that her friends noticed that she would have some chewing movements during such events. She would experience 2 to 3 such episodes every month. She tells the doctor that her memory for faces and pictures is not that good. She also mentions that she had a prolonged febrile seizure when she was 4 years of age. So what is the diagnosis of her present episode? I think we have the polling option. If the audience can actually vote on the options, that would be great. Can we have the polling option? Okay. We'll give about 30 seconds for people to answer. And then let's move on. Okay. Shall we close the poll? It's a very simple question, I suppose. Do we have the results? Okay, so so we've got the majority for number 1. Sorry, so most have actually, there's a split between dissociative seizure and generalized tonic-clonic seizure with the vagal syncope lagging behind. Okay, let's move on to the next question. So what is the next step in the evaluation of this patient? You can open the poll right now, and then you can answer. Okay, I think we can close the session. So majority are for ordering imaging and EEG. All right, okay, so I'm not going to answer the questions. Let's move on to the lecture proper, and then try to answer the questions again after a little bit of input from the lecture. Right, okay. So as all of you must be aware, epilepsy is one of the most common neurological diseases in the world, and it affects approximately 1% of the adult population and between 0.4 and 0.8% of children. So it's quite common, and it's one of the commonest neurological disorders in the world. When you encounter a patient with suspected epilepsy, there are several. The analysis or the approach should be a stepwise approach, and you need to ask several questions in your. You need to ask questions in your head and try to see whether you can answer these questions which I've actually posed on my slide. So the first question is this a seizure is this a seizure or are these seizures? So it depends on whether the person comes with or the said patient comes with a single event or multiple events. Are these really seizures in the first place? That needs to be answered. Is what type of seizure? If it is indeed a seizure, what type of seizure is it? If it is indeed if you identify the type of seizure, is this epilepsy? So I will talk about epilepsy and seizures in a little while. And if it is indeed epilepsy, what kind of epilepsy is it? And what caused the epilepsy? And what investigations that you need are needed for the evaluation of this patient. So these are the main questions that you need to ask yourself when you are indeed evaluating a patient who is suspected of epilepsy. So the first question, the initial step in evaluation of a seizure, is this really a seizure? And you need to differentiate true seizures from what we call seizure mimics. And there are a whole load of seizure mimics that are erroneously diagnosed as seizures in the first place, and they can include syncope, transient ischemic attacks, migraine auras, paroxysmal movement disorders, sleep disorders, intracranial hypertension, and even psychogenic non-epileptic seizures. Now, when it comes to the adult, the common three the common two seizure mimics that we generally encounter in clinical practice is syncope and non-epileptic seizures, or psychogenic non-epileptic seizures, or dissociative seizures, and often they're misdiagnosed as generalized tonic-clonic seizures. And we see that quite a bit, that a lot of patients actually diagnosed with epilepsy and started on anti-seizure medication when they actually are having one of these two conditions. And there are certain sort of clinical features that you look for. For example, in a generalized tonic-clonic seizure, you need to look for evidence of cyanosis, and the absence of pallor versus pallor, which is more prominent in syncope. The presence of a nictal cry, stertorous breathing, lateral tongue. If the tongue is bitten on the lateral aspects, very specific, seen in about 1 in 5 of patients with generalized tonic-clonic seizures, and it's nearly 100% specific to that of a generalized tonic-clonic seizure, as opposed to a tongue bite as a consequence of either syncope or non-epileptic seizures, which also you might experience. The patients might experience, but the location is at the tip of the tongue, as opposed to the lateral aspect. The post-event confusion, drowsiness, muscle aches, all are features of generalized tonic-clonic seizures, compared to that of syncope, where there's almost always a prodrome where they have the changes in vision, tunnel vision, blurred vision, diaphoresis, feeling of nausea, warmth, and the situation is also very important, often precipitated by prolonged standing, and often the recovery is quite rapid. And when it comes to non-epileptic seizures or dissociative seizures, here the seizures are more prolonged. Often seizures, 99% of seizures terminate before 2 minutes, and that's very important. Timing of the event is very important, and on average, a seizure would last 1 minute and 6 seconds, and that's on average, and that's quite a short period of time. It's shorter for syncope, longer for seizures, but extremely long when it comes to non-epileptic seizures. So if a patient comes with very long seizures, you may need to consider the possibility of non-epileptic seizure. The gradual onset and termination, fluctuating courses, it has often the histories of a waxing and waning pattern. There might be other markers within the semiology where there's lateral sort of side-to-side movements, asynchronous movements, opistotonic posturing, being emotional following the seizure, like crying after the seizure, all of which might suggest that this may be, you may be dealing with a non-epileptic seizure. Just remember, a lot of people go by this, the fact that someone might be incontinent, to urine. That can, if someone has a full bladder and loses consciousness or has a syncopal attack, the said patient will lose continence to urine. So that's not a predictor of a seizure. The other aspect is that there might be increased tone or myoclonic jerks associated with syncope. And often the increased tone and the myoclonus is taken as a marker of a generalized tonic-clonic seizure, which is often in error. Just want to highlight what could happen. This was actually experiment done on German medical students. What they did was they hyperventilated and suddenly stood up, and see what happens. And can you see the myoclonic jerks that are associated with a syncopal attack? And that can be easily misdiagnosed as a seizure. Just want to say, right? There can be increased tone, myoclonic jerks, all of which are suggestive, can be suggestive of a syncope rather than actually a generalized tonic-clonic seizure. All right, an increased tone, so just like a log. So you don't have to have absence of tone. So you might have increased tone associated with syncope as well. These are this is a non-epileptic seizure or a dissociative seizure. What I wanted to highlight is the so it's obvious non-epileptic seizure. The waxing and waning pattern, the lateral movements of the head. Just wanted to highlight that because when you actually ask eyewitness of the episode, they'll say that the whole body was shaking, and based on that, a lot of people would start on some sort of anti-seizure medication. But if you're not sure, I think getting a video of the event is very important in trying to diagnose whether these are true seizures or not. Next is also a non-epileptic seizure. What I wanted to highlight in this case is that she loses awareness. That was a history, and then she's unresponsive. And during the event, what I wanted to highlight is the resistance to the opening of, trying to pry open the eyelids. There's some resistance. So that again may be a sign that you're dealing with a non-epileptic seizure or a dissociative seizure. Right. So is it a seizure? Then if it is indeed a seizure that you're dealing with, then what type of seizure? And the International League Against Epilepsy has actually classified seizures into focal, generalized onset or unknown onset. So the seizure semiology is very important, and the onset of the symptoms or the semiology is the most important thing in classifying these the seizures into focal onset, generalized onset, or unknown onset. So, for example, if a patient comes with a aura, say an aura of fear, and then loses awareness, right? That is a patient who has a focal onset seizure because of the fact that he or she loses awareness. It's a focal onset seizure with impaired awareness, and the onset is the most important thing. The first symptom or semiology, that the first feature in the semiology is what we go by, and therefore the onset is not motor, but it's non-motor onset. And since it's an emotion, fear is an emotion, so it's an emotional seizure. So it's non-motor onset, emotional, focal. So it starts with focal onset with impaired awareness and going down to non-motor onset an emotional seizure. So if it's a generalized seizure without any features of clinical features of focality, then we go by again whether it's motor or non-motor, and so on and so forth. So the classification of a seizure into focal onset, generalized onset, and in some cases we are really not sure. Based on both the seniology or based on the history, we're not really sure whether what the onset is. Then we classify those particular seizures as unknown onset. As you can see, the nomenclature has completely changed, and I would advise to use this particular nomenclature as opposed to the previous one where we use simple partial seizures, complex partial seizures, and generalized seizures. So that nomenclature is not used anymore. The secondary generalized seizures, which we used to define, is now reclassified as focal to bilateral tonic-clonic. So there are some changes in the nomenclature, and it's very important for you to classify as to what type of seizure you're dealing with. So once you've identified what type of seizure, then it's important for you to identify what type of epilepsy you're dealing with. And are all seizures, or are all patients with seizures having epilepsy? The answer is no. So the important thing is to identify whether these seizures are provoked versus unprovoked. And if they are truly unprovoked, then do they fulfill the criterion or criteria for diagnosing epilepsy? And those are the questions that you need to ask yourself, right? So is this really epilepsy that I'm dealing with? So what are provoked seizures? So for you to identify unprovoked seizures, you need to identify what are provoked seizures. And what are provoked seizures are seizures where there is a transient decrease in the threshold due to either a direct insult to the central nervous system or an indirect insult, which may be a systemic insult, where there is a transient decrease in the threshold, patient gets seizures, and once the condition is normalized, the patient doesn't have seizures anymore and is not likely to have seizures in the future. And that's why these patients, it's important for us to identify these patients or these type of seizures as provoked seizures, because these patients or this cohort of patients do not really need long-term anti-seizure medication. And examples for these insults include fever. So when you're very young, you can have febrile seizures, infection to the brain, like meningitis, encephalitis. Syncope can always cause a secondary anoxic seizure. Metabolic derangements such as hyponatremia can cause provoked seizure. So it's very important for us to identify whether this is a provoked seizure or not. And the timing is the most important thing. The temporal association with the particular insult. For example, if it is a central nervous system insult, the seizure is often within the first week of that insult. For example, if a patient comes with a stroke or a traumatic brain injury, if the seizure occurs within 1 week of the onset of that particular insult, then those seizures are classified as provoked seizures as opposed to unprovoked. If it is beyond that time period of 1 week, then they are often classified as unprovoked seizures, and it's very important for us to identify the distinction. If it's for a metabolic derangement, or if it's indeed due to a toxin, which can also be the case, then the time period is generally considered 24 hours. And if it is beyond that period, it may be that you're dealing with an unprovoked seizure. So the temporal association is as important in defining whether these criteria for diagnosing epilepsy. Now, maybe about 15 years ago, the first criterion in which you needed 2 unprovoked seizures, which are 24 hours apart, was the diagnosis of epilepsy. And now the epilepsy definition has actually expanded, and even after a single unprovoked seizure, we are able to classify certain cohorts of patients as having epilepsy. And if their risk of recurrence over the next 10 years is over 60%, even after a single unprovoked seizure, we are now able to diagnose epilepsy based on the data that we have over a period of time. For example, if a patient with a stroke, a previous history of stroke, comes with a seizure which is anatomically attributed to the area of a deficit many months after the stroke, then that particular patient has a chance of recurrence of seizures of approximately 70% over the next 10 years. And even after a single seizure in that particular clinical scenario, that patient may be diagnosed as having epilepsy. So a single seizure can be used as a marker for diagnosing epilepsy. Also, there are certain epilepsy syndromes which one needs to be aware of. And what do we mean by epilepsy syndromes? So epilepsy syndromes are a group of patients where the features within that cohort of patients are very, very similar. And they are generally defined by clinical features, seizure types, age of onset, family history, EEG findings, diagnostic investigations, treatment, and prognosis. For example, very common childhood epilepsy syndrome is childhood absence epilepsy, where the predominant seizure type is absence seizures, and there's a typical age of onset, generally between 4 years and 12 years, and generally peak age of between 4 to 6 years of age. Then they have a very characteristic EEG pattern with a 3 Hertz spike and wave discharge pattern, and they have a very prognosis which is age dependent. So by the time they're teenagers, the epilepsy is no more. So this particular cohort of patients have very similar characteristics, and based on these characteristics, they are diagnosed as having a particular epilepsy syndrome. So I'm an adult neurologist, and therefore these are the epilepsy syndromes that we generally deal with in adolescence and in adulthood, of which the first 3 are the epilepsy syndromes that we generally deal with: juvenile absence epilepsy, juvenile mild clonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. The other 3 are not very common. I'm not going to deal with the various clinical features of the epilepsy syndromes in this particular talk. What kind of epilepsy is the next question? So the ILAE has classified, again, based on the seizure type, it's a basically multi-level classification. And based on the seizure type, you generally classify the epilepsy type into, again, focal, generalized, combined generalized, generalized and focal, and unknown. So this is the graphical representation of the multi-level classification. So you first start with identifying the type of seizure. So if almost all your seizures are focal in onset, then that particular patient has a focal epilepsy. If the seizures are all generalized in onset, then they are classified as generalized epilepsies. If they have both a combination of focal and generalized, then they have a epilepsy type with combined generalized and focal. And of course, if it is unknown, it is unknown. And again, we try to see whether these patients fit into an epilepsy syndrome. And while trying to classify the type of epilepsy, we also need to find out what the cause for the epilepsy is, and we'll deal with that, or etiology of the epilepsy. We'll deal with that in the subsequent slides. The other aspect is to actually identify comorbidities that are associated with the epilepsy, because that might have bearing in the treatment and management of these patients. For example, concurrent anxiety, depression, increased BMI, all of which might actually contribute in your decision on how to treat these patients. With regards to the cause, there are, if you go to this slide, there are the cause is basic, or the etiology is classified into 6 categories: structural, genetic, infectious, metabolic, immune, and unknown. So structural causes, any structural cause within the brain, the cortex of the brain often, and that can be attributed to the actual seizure semiology. So it has to be compatible. The anatomy and the seizure semiology should be compatible for you to attribute the cause as a structural lesion, because there are instances where there can be incidental structural abnormalities when traumatic brain injury, stroke, tumor, birth injury, brain infection, etc. can all cause structural lesions, which can eventually result in epilepsy. Genetic causes, so there are several single gene mutations that can result in epilepsy. These are some of the examples, quite rare, but seen associated with certain types of epilepsy. Just to give you some examples of single gene mutations, often they are channelopathies that give rise to such epilepsies. Then we've got often after the infection, following the infection, secondary to a structural lesion, patients can have epilepsy. And of course, the commonest infection worldwide, but not so much in Sri Lanka, is neurocysticercosis. Of course, TB, HIVs, malaria, SSP or subacute sclerosing encephalitis, panencephalitis, cerebral toxoplasmosis are all examples of infection that can give rise to epilepsy. Of course, even infection during the perinatal period, such as CMV, can cause structural lesions, such as malformations of cortical development, which can eventually give rise to seizures. There are certain metabolic causes where that can be either due to production or breakdown or deficiencies in the breakdown of natural substances within the body that can give rise to epilepsy. For example, amino acidureas, organic acidureas, and so on. Deficiencies in certain cofactors can give rise to epilepsy as well. For the last 10 to 15 years, there's been an increase in recognition of autoimmune causes or inflammatory causes as causing epilepsy. And examples are, as I think a lot of most postgraduates would know, is an NMDA, GAD65, and LGI1 antibody-mediated epilepsies are now increasingly being diagnosed. So what are the investigations that you would generally sort of order in these patients? So the basic blood works, which includes an electrolyte, calcium, glucose, and even in certain cases urine toxicology, are very important in trying to differentiate whether these the seizures are really provoked or unprovoked, and that's when these investigations become very useful. And it may not be that useful in the non-acute setting, but in the acute setting, almost all these patients who experience seizure to find whether these are really provoked or not. And EEG is important, often not in situations where you're dealing with provoked seizures, but indeed in unprovoked seizures. And what you need to know is an EEG is useful in identifying the chances of recurrence, and is not as useful in actually diagnosing whether this patient's got epilepsy or not. And that's because the more important thing is actually getting an accurate history, and that's the most important thing that I need to emphasize today. So just because you have an EEG does not mean that that you might be able to diagnose whether the patient's got epilepsy or not. And you need what you need to know is that a normal EEG does not exclude the diagnosis of a seizure. And in most cases, even if you're dealing with an epilepsy or a seizure or a seizure, in over 50% of patients, the EEG can be normal. The other forms of EEG are ambulatory EEG and video telemetry, only done in certain circumstances and in certain centers, not really available. Video telemetry can be useful in trying to, again, diagnose patients when the clinician is unsure of what kind of paroxysmal event that particular patient is having. And in those cases, the video telemetry can be useful. And also in cases where we are dealing with resistant, pharmacoresistant epilepsy, where we are looking for a intervention like a surgical intervention for those particular patients, video telemetry can be useful. Imaging, again, useful in trying to find a structural cause. CT is the imaging of is not the imaging of choice in unprovoked seizures, but certainly in the emergency setting, looking for a provoked cause of a seizure, CT can be very, very useful. MRI can be useful in trying to predict recurrence and trying to define an etiology. Often abnormal in the setting of an abnormal neurological examination, focal seizure activity, or focal findings on EEG. Other imaging modalities are generally used as in very, very specific circumstances like SPECT and PET, especially in patients when we are evaluating these particular patients for epilepsy surgery. Right, going back to the case. So I'm not going to go through the case history. If you can remember, let's go back to the answers. What is the diagnosis? Can we have the poll? Okay. I think we can close the poll. Yeah, so after the lecture is correct. It's actually a vasovagal syncope where the patient loses, there's tunnel vision before the, where the patient actually loses consciousness. She does have myoclonic jerks, but that again can be observed in vasovagal syncope. So that's correct. How do you classify the seizures? So this was a seizure with, so she's got seizures in her medical history and is probably having epilepsy. So we need to classify what type of seizure is it. It is. So it's a focal onset seizure, obviously, with multiple auras, fear, aura of fear, and an epigastric sensation. So it's a seizure with focal onset, impaired awareness, because the patient loses awareness. She's got epigastric aura, which is autonomic, and she's got an aura of fear. I've mentioned autonomic, but that's in error. It's actually the important thing in classifying the seizure is the semiological aspect or the feature that occurs first. So if it's fear, the emotion of fear that occurs first, then this patient should have a classification where it's focal onset, impaired awareness, non-motor onset, which are emotional and not autonomic. But if the epigastric aura occurs first, then it should be reclassified as autonomic. Hope that was clear. And since she's got focal seizures, she's got focal epilepsy. And we need to look for a cause, and therefore imaging might be very useful, because she's got focal onset epilepsy, and she's got a history of febrile seizures in the past. She's got seizures with a semiology which is consistent with the temporal lobe seizure, with the mesial temporal lobe or medial aspect temporal lobe epilepsy, with a quiescent period where she's not had any seizures after her febrile seizures, and then the seizures started in either early 20s or in her teenage years. That particular syndrome or symptomatology is consistent with a certain diagnosis. So what is the next step in your management? What is the answer? Can we open the poll? Okay, you close the poll. Right, so almost all of, and most of you got it right, EEGs or imaging. And in this particular patient, because of a semiology and the characteristics of a history, she's got what's called hippocampal sclerosis, where there is flat. You can see a signal change on the MRI in her right hippocampus, and the anatomy or the architecture of the hippocampus is altered. So this is a very specific syndrome. It's now classified as a specific syndrome, which is hippocampal sclerosis. Okay, so that's the end of my talk. If there are any questions, I'm happy to answer. I think I've gone a little bit over time. Apologies for that.
Dr. Kishara, thank you very much for that elaborative talk on evaluation of epilepsy. So we're running short of time, but still can entertain a couple of questions. So just let me ask questions which have been posted on Q&A. So the first question from one of our dearest teachers, Dr. Raghunathan. So I'll read up the question. Once Professor K.D. Pathirana presented long years ago a practical way of differentiating NEAD from true seizures by suggestion using a placebo. I found this often useful. What are your views on this suggestion with a placebo? If I remember, this paper won GMA award many years ago. Yeah, thank you, sir, for the question. Over to you, Dr. Kishara.
Very good question, sir. It's the two patients on the videos of the two patients were actually patients which we diagnosed as non-epileptic seizures when I was, I think, a senior registrar, and that at that point of time, what we used placebo to induce these seizures, the school of thought at this point of time is that it's very useful, and often patients with non-epileptic seizures or dissociative seizures are very, very suggestive. And unfortunately, I think most of the world or the epilepsy world or patients, the experts are not in favor of this particular induction to induce these seizures because of the ethics that are that surround this particular sort of procedure, where we have to be untruthful to the patient and try to trick the patient into having a seizure. So the moment, I think the consensus is that we try as much as possible not to trick the patient. But we can always use a suggestion, as you can always say that you've reinforce that you might get a seizure in the next few minutes. Seizures that occur in front of the practitioner is often a non-epileptic seizure. So at the moment, I think because of ethics, problems with ethics, it's not in favor. I hope that answers the question.
Yeah, so Dr. Kishara, based on the case, there's a question. In the case scenario, despite vasovagal syncope, why do you investigate for seizure?
The medical history is also having, so she's got a medical history suggestive of multiple seizures. According to the classification, we need to so she's got both non-epileptic events, which are vasovagal, and she's got epilepsy. So as I suggested, you need to find a cause for the epilepsy, and then depending on that, you treat the epilepsy. So etiology is very, very important. So you need to do a structure, MRI or CT or whatever imaging modality to exclude a structural cause. And in this case, it's a structural cause involving the temporal lobes, the medial aspect of the temporal lobe.
Okay, thanks. Just one last question. Now, you spoke about the role of EEGs when evaluating epilepsy. So when somebody is requesting EEG, are there any special requests to be made? If so, when should you request, like sleep deprivation, photic stimulation, and
you mean activation? Yeah. So often we use EEG for one is to gauge the chances of recurrence, right? Two is to in certain and also give us a clue as to what type of epilepsy that we are dealing with. In sense, are we dealing with a epilepsy syndrome? So in certain instances, certain epilepsy syndromes and certain types of epilepsies can be activated. For example, if you are dealing with an absence epilepsy, often it is activated by hyperventilation, and we generally and that's generally part of the protocol of an EEG, where we tell the patient to hyperventilate for approximately 3 minutes. There are other types of epilepsies which are reflex epilepsies, which can be photosensitive. So in certain cases where we suspect that these patients have photosensitive epilepsy, or indeed in certain cases of even genetic or idiopathic generalized epilepsy, we would request for photic stimulation as well. In the case where we are, there are certain types of epilepsies where where the interictal discharges are activated by sleep. So in those cases, for example, benign epilepsy with centrotemporal spikes, the nomenclature has changed. In that type of epilepsy, it's the epileptic discharges are more prominent during sleep. So what we would generally request for is a sleep-deprived EEG, where the patient actually sleeps throughout the EEG. So again, it's the clinical diagnosis, and depending on the clinical diagnosis, then you request for the various activation procedures. I hope that's clear.
Yeah. So thank you once again, Dr. Kishara, for the talk on epilepsy. So from epilepsy, next we move on to dementia. So to talk about how to evaluate a dementia patient at the bedside, we have Dr. Manjula Caldera, who is a consultant neurologist attached to Teaching Hospital, Anuradhapura. Over to you, Dr. Manjula.
Thank you, Kumarangi. Hope you can see my slides. And I would like to thank the College of Physicians and the Association of Sri Lankan Neurologists for asking me to do this talk. It's, I think, something not many are comfortable with, especially in the assessment of the neurological examination. The cognitive assessment plays an important role, especially when it comes to assessment of the dementia patients. So I'll try to do it very concisely for a busy clinician, how to sort of adopt various assessment techniques in a busy ward round, and probably how to digest what's in the standard bedside cognitive assessment tools. Now, the agenda is to discuss commonly available bedside cognitive tools, one, then different domains of cognitive assessment that are elaborated on these cognitive tools, and then how these cognitive assessment could help to differentiate dementia syndromes. Now, most of you may be familiar with these assessment tools like Addenbrooke Cognitive Examination ACE-3, then the Mini-Mental State Exam, and then the Montreal Cognitive Assessment, or abbreviated as MOCA. Now, they are validated in Sinhala as well, and some of them are validated in Tamil as well. I'm not going to do these cognitive tools, but they are trying to assess certain domains of cognition. So I'm trying to elaborate like how to understand these different domains, and then how it is going to be related, or how it's going to be differentiated from to dementia syndromes. Now, this is a summary of these different commonly available cognitive tools, and the time usually sort of taken up for an experienced person, and then the cutoff values. Now, an MMSE would take from 5 to 10 minutes, while Addenbrooke cognitive assessment would take 15 to 20 minutes, and a MOCA in moderation about 10 minutes. The cutoff values in MMSE, 24 out of 30 would be taken as a cutoff for dementia, which has about 87% of sensitivity. And in the ACE-3, 88 been taken as a cutoff mark, which have a sensitivity of 100%. But if you lose the cutoff, the figures will become different. And the MOCA, 26 out of 30 would be taken as the cutoff point. But mostly that you need to understand if you're doing a research, especially the MMS is copyrighted, so you might have to use ACE-3 or MOCA, or if you want to sort of choose MMSE in your cognitive research, you have to get you have to pay for them. It's very expensive. Now, using these tools as your sort of spine of the talk, we'll try to come to the cognitive assessment. In any assessment, you have to have a general assessment. You need to take a little bit of history about the patient's general condition, how the patient behaved pre-morbidly before having the cognitive complaints, like what level of education the patient had, what kind of employment the patient had, and what are their hobbies, because you need to have a conversation with the patient. And this pre-morbid functioning is important to have a conversation with the patient. And that also will be helpful to direct our conversation to various aspects of the memory components. So it's very, very important to have patients' level of background. And then the onset and the time course of the deterioration of the cognitive functions are an important, because this onset, whether it's acute or whether it is subacute or whether it is something progressive, insidious onset, which would give us some idea about the dementia process, whether the pathological process would be elaborated by that. Then it's important to interview both the patient and the informant both together, because sometimes patient may be completely unaware about their cognitive deficits, but the informant would elaborate largely about the patient's deficit. But patient, if you ask like whether you have problems, he might say, no, I don't have any problem, I'm fine. And then the family history and the risk factors are important. Some cognitive, some dementia syndromes are genetically driven. So you need to have a family history, whether there's any significant family history, maybe like Huntington disease, or maybe sort of young onset Alzheimer's disease, or some familial frontotemporal dementia. Those are sort of important. And the risk factors, like vascular risk factors, especially for vascular dementia, and certain drugs that we'll come to later, the concomitant illness and the medication has to be elaborated, because some cardiovascular risk factors and then medications like psychotropic drugs especially like tricyclic antidepressants or benzodiazepines can impair the cognition. And then you need to have an awareness about the patient's functioning, whether it is legal to perform driving, what kind of activities or daily living that the patients can perform, and what are the deficits, and how can you help with your suggestions. This background knowledge is important in the general management of a dementia patient, and then to sort of have an in-depth assessment. These are the cognitive domains that we are going to describe. These domains are tested to certain degrees in various cognitive tools. Number one is attention and orientation, which is a must that you need to have before going into the other cognitive domains. If the patient doesn't have attention and orientation, you can't go beyond. Then the memory, language, then executive and other frontal lobe functions, apraxia, visual spatial ability are important domains of cognitive assessment that we are going to assess. Attention and orientation is important. That orientation to time, place, and person is something really need to know, because if a patient is not oriented, you consider acute confusional states like delirium, you might not be able to do a useful cognitive assessment. So it's very, very important. And then the attention, there are various ways that you can check it. If the patient is good in arithmetics, probably serial 7 test could be done. But if the patient is not good in that, perhaps you can do a digit span, which is you tend to tell 1 digits per second, and then you ask the patient to tell repeat it. And normal digit span forward is something 6 or 7. And if the patient has lesser values, then you consider the patient's attention is deficits. And you can do a backward digit span as well. So the normal backward digit span is about 5. And then you can ask a word to be spelled backward. Standard in the English is being given as world, W-O-R-L-D. You can ask the patient to spell it backward. In Sinhala or Tamil, you can use a simple 5-letter word, like something in Sinhala would be like Samanala, which is used in the Sinhala translated MMSC. And then the month of year, or in weeks, the days of week could be used to mention in reverse order. What I used to do, I used to tell the patients, tell the months of year, and then patients start from January to December, they tell, and then I ask them, now tell them in backward. So, and then you can assess how much the attention span of the patient. So this thing to be done at the beginning before you go into a proper cognitive assessment, because if the patient can't perform these functions, to go to a higher level of assessment may be futile. So you need to have a good attention and orientation to perform a good cognitive assessment. Now, then it comes to the most important cognitive domain is memory. Memory, you need to, you will be classified as episodic memory, working memory, and semantic memory. Now, I'll first mention what is the working memory, or known as the short-term memory, which is the memory that you utilize to retain information extremely shorter period that could be quickly retrieved. That you can do by the registration process in the MMSC by mentioning 3 objects to be remembered and then quickly retrieve that. That is working memory. Or even in the digit span that you measure is working memory. So so that is actually not been considered as sort of a memory disorder, because that's mainly the ability to keep the attention on. So it is not come as sort of in memory disorders, because it's come as sort of attentional deficit problem. Now to the memory proper, the episodic memory, Episodic memory is considered as the personally experienced events that if you recall, like in this webinar, if somebody asks like, when did you log into the webinar, when did you get the email alert, or when did you see the flyer from the CCP, and that memory is your episodic memory which related to this webinar. Or probably you might ask like, what were the questions Dr. Kishara called the answers for. That's your episodic memory. Those are the personally experienced events. There are such events in your life which are important and then remembered by you. Now, these episodic memory could be classified as anterograde memory or retrograde memory. The anterograde memory is the newly formulated memory from a particular point, and retrograde memory is a past event from that particular point. Now, this particular point is related to the pathological process of dementia disorder. Perhaps we'll say like, we have a head injury and then you lose your memory. The events after the head injury, the memory related to the events after the head injury is considered as anterograde memory, and the events before the head injury is considered retrograde memory. Likewise, if we'll say like, if you are going to develop Alzheimer's disease, we don't know like what exactly that we started this pathological process. We'll say like, if it's happened 2 years back, and from that point onwards, the newly formed memory is considered as anterograde memory. So it's very much related to the pathological process which affect the memory. So once you get this episodic memory into your brain, maybe by experiences in your school, maybe your training programs, maybe by your news, by entertainment or whatever, that knowledge stored in the brain in a different domain, which is called the temporal lobe, as the semantic memory. That semantic memory is not related to the experience or events, but that is the extract knowledge from that. So it's kind of the meaning of various words that you accumulated throughout the general knowledge. That's will be sort of saved as a general knowledge. Now, most of the people were unheard of tsunami until that we had the tsunami in 2006. But since then, you learn a lot about, and then that's become your general knowledge later on. So people who experience the tsunami, that is your episodic memory. But then whatever details that you gathered and the general knowledge of tsunamis and how they occur is your semantic memory. Now, episodic memory is largely being dealt by the hippocampus, and then it's a circuit, hippocampal diencephalic system, that is commonly affected in Alzheimer's disease, and also can be affected by herpes simplex virus encephalitis. You know, that affects the temporal lobes, and then the transient global amnesia and transient epileptic amnesia. Now, we discussed the anterograde memory loss, anterograde memory in the previous slide as well. So how do you check that, or how do the people present with anterograde memory, they forget recent personal and family events? Perhaps sort of if somebody's birthday happened the previous week, they completely forget that event, or they might forget the important social occasions. Perhaps if it's happening Christmas or New Year or whatever recent festive events are sort of erased from the memory. And because of that, they tend to ask questions about the same thing, because you have forgotten that recent thing. And once you ask a question, the answer is obtained, and then again you forget that. So you tend to repetitively asking the same question, which is the most annoying thing for the family, which the family tend to seek treatment for the patient's forgetfulness. And these patients probably find it extremely difficult to remember or follow the plots of the movie or TV shows, because and they probably might ask from you, like, what happened there, why this person is marrying the other person, because all these sequences cannot be correlated, because the memory lapses these patients are getting. How do you test the episodic memory? In MMSE, you do recalling 3 objects. So what you do, you give 3 objects to be remembered, and you immediately ask which is testing your working memory, and that is being considered as registration. An address that you're registered and then recall later. Now, the retrograde memory is mainly the past events, past jobs, where you lived in the past. Major news events could be like, you can ask if it's a cricket fan, when Sri Lanka won the World Cup, and who was the captain then, who were the opening batsmen. Sort of that's all sort of related to the patient's hobbies and the interest that you have to ask the patient. If the patient is not a cricket fan, then ask politics or whatever the patient's field of interest. Then if a patient lose episodic memory, and if there's sort of a informant by the side, this head turning sign is a very, very important thing, and of episodic memory loss. Now, if you question about various personal events, if the patient is not sure of the answer, always sort of turn to the spouse or the daughter or son to get kind of reassurance whether the answer is correct, or to get some help from the informant. So which is called head turn sign, which is being verified in research. That's sort of a marker of loss of episodic memory. We mentioned the working memory, which is dealt by the dorsolateral prefrontal cortex, which is important, because most of the time when you encountered patients who complained of, I have memory problem, the patient comes and complains that I have memory problems, actually what they are referring to is working memory. Most of the time they notice lapses in their concentration and attention as a memory problem. They may wandering into a room and forgetting the purpose of the visit, and then later on they'll realize that I came to the room to collect that particular cloth or collect that particular book or something like that. Or they probably open the door of the fridge and then trying to remember like what I came for the fridge, and then close the door and then go back and then realize that I want to sort of get a fruit juice or something like that. So these are the concentration lapses that the patients have, because that's common, is seen with increased age. Sometimes people with depression and anxiety as well. So you need to reassure these patients, as they are not having a dementia disorder, but this is quite common, and it may be one of these, like anxiety, depression, and anxiety, the increased age. Of course, other than the increased age, you can treat the other 2 conditions. In these type of situations, usually the patient comes alone. They don't come with a family member, because the family members are not much concerned about these things, but they are quite self-centered, and then the patients are more concerned about their working memory lapses. Most importantly, you need to reassure the patient. Then we'll come to the semantic memory. we discussed that it's a general fund of knowledge which is accumulated as episodic memory in the past, which mainly led by anterior temporal lobe, and that commonly related to the language component of the memory that will dealt later. And sometimes there are non-verbal part of the memory as well. Like face recognition. Dr. Kishar also mentioned in his talk in the temporal lobe epilepsy case where the face recognition came to an issue. Now, these are considered as a non-verbal memory. So what is this language function assessment? It is tested in various ways in various cognitive tools, but you can do the language assessment by from taking the history. Listening to the history will reveal that the deficits the patients have, like the comprehension of what your questions are, and how the patients formulate the answers, what is the fluency, what is the prosody, is there grammatical errors, how the patient articulates, does the patient use correct words in proper places, are there any paraphasic errors. Likewise, you can understand whether there's any impairment of language function. Now, these language functions can be tested by various ways, by like naming objects that you can see, which is utilized or which is available in the Addenbrooke cognitive scale. These commonly affects in post-stroke aphasias, and they can be affected in Alzheimer's dementias and semantic dementias as well. Mostly they are affected in the semantic dementias. The paraphasic errors are kind of three types. Phonemic paraphasia is where you make word substitution, which are kind of rhyming like, sound similar. A person can be a substitute cheater for teacher, and the semantic paraphasias are the words that you substitute inappropriately but have some kind of similarity, where you may tell a watch as a clock or vice versa. And then the broad subordinate responses, like if you know this is a German Shepherd or another category of a dog, but you might sort of use, instead of the particular breed, as an dog, or more broad subordinate responses like an animal. Perhaps sort of a particular object, maybe a table or a chair, could be considered as a furniture, because the patient find it difficult to get the correct word for that. Or even if the furniture is difficult to be found, when people are deteriorating, they might use that thing, this thing, likewise. So they are commonly seen in semantic dementias. And then the comprehension is also would be assessed by recognizing various objects that you can use, which are available with you. You can use your keys, pens, watches to sort of ask, test the comprehension when you're interviewing the patient. And then the sentence comprehension, also you can sort of use a single step, double step and triple step commands to make it more difficult for patient to comprehend and sort of see how severe the patient's comprehension is. And then the conceptual comprehension, like which of these items is used for recording of passage of time. You give 3 objects and sort of ask the conceptual comprehension, and if the patient can find the watch as a correct item, that is kind of called conceptual comprehension. And then the repetition of words also important, which important part of the assessment of the language. You can use one syllabus, and then double and triple syllabi could be used. Like you can ask the patient to repeat let's say pa 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 pa, which assess kind of lip function, and then ta 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 ta, the tongue, and then the hard palate which comes into, and then the ka ka ka, which is your the pharynx come into play, and those functions would be helpful to assess the desire, the repetition part, which is important in the language function. The repetition especially affects in progressive non-fluent AFI, which is a rare kind of primary progressive aphasia type of dementia disorder. Now, this executive and then the frontal lobe functions are important in a group of dementia called frontotemporal dementias, and they are quite complex and quite extensive. But to make it more simple, I'll try to do a few which is available in most of the cognitive batteries. The problems with the people who have executive and frontal lobe functions can have problems with the planning, judgment, problem solving abilities. These people who would be able to sort of plan a vacation, perhaps sort of booking tickets and arranging accommodation, various hotels, and then what kind of recreational activities to do. Now, when these patients lose their frontal lobe functions, they're quite dependent on others to plan the things because their executive functions are being affected. So that comes in the history. Probably might not be able to sort of check quickly them in a battery. And then the impulse control ability is also another important frontal task. Sometimes people quite difficult to control their impulses. Sometimes people will develop addictions, maybe addictions to video games or various sweets, or maybe sort of most embarrassing things like addiction to pornography and other things are also considered. And then the abstract reasoning is also something which explains your executive functions. What are abstract reasoning is something like if you ask a proverb, perhaps a bird in the hand words than the two birds in a bush or something like that. What that's meaning, or all that glitter is not gold. That kind of proverb meaning something like too many cooks spoil the soup. Like if you ask like what is the meaning of that, they might not be able to sort of get the essence of that proverb. They might say if you have too many cooks, they will not be able to sort of do a proper soup like thing. So they try to sort of come with a reasoning with the exact words rather than getting the meaning underneath. Or sometimes what you can do, like you can show a pen and a paper and ask like what is the common between them. So people find it difficult to sort of relate the pen and paper and say like this is using for writing or something like that. And so likewise these people have executive dysfunction. In most of in an Addenbrooke cognitive assessment, executive functions could be checked by category and letter fluency. The letter fluency, they give 3 letters, F, A, and S, and one of the letter could be given, and then trying to make as much as possible words within 1 minute. In singular translation for the Addenbrooke, you give letter sir and to make as much as words within 1 minute, and that is low in frontotemporal dementia. The category fluency is actually not a frontal task mainly, which is you give a broader category like name animals or name vegetables or name flowers, like you give a category to sort of name things as much as possible within a minute, which are quite low in people who have semantic dementias and Alzheimer's dementia. Now, we'll come to another important aspect of cognitive domain, which is called apraxia, which is inability to perform a movement with a body part despite intact sensory and motor function. So you need to have the sensory and motor function. So that doesn't mean that if you have a stroke and if you have motor deficits, then you don't call it apraxia. That because patients lose the motor ability or the sensory ability to perform the movement. But while having the ability to perform with motor and sensory functions, but inability to perform that movement, that planning of the movement is being affected, and that's called apraxia. Now, how you can check the apraxia is by easily by imitation of gestures that could be used to check the praxis of the orobuccal movements as well as the hand movements. Now, various gestures could be demonstrated to the patient by your hand, as it's demonstrated in the illustration, and then you ask the patient to do the same. I also again mentioned that patients should have the motor ability to perform these tasks. Now, when these patients find it extremely difficult or take a lot of time to guess the gesture and then pantomime the gesture, then you call the patients have praxis problems. They are can happen in the orobuccal movements as well. Like you can say to blow out a candle, or stick out your tongue, or try to cough, or show how to lick your lips. And if the patient find it difficult to do these movements or imitate, then you think the patients have praxis problems. Praxis problems commonly happen due to parietal lobe damage, and these commonly seen in corticobasal degeneration disorders. And then we'll come to the last part of the cognitive domain, which is called the visuospatial ability. Various cognitive tools use various visuospatial tests to be checked. You probably more comfortable with intersecting pentagon, which is available in the MMSC, which you have to ask the patient to copy it down. And if it is possible, then you can use a more complex figure, which is shown on the right side of the intersecting pentagon, which is called a wire cube, which is quite challenging for a person with the visuospatial ability to copy it down. And then the intersected letters that you see on the Addenbrooke. Of course, a person like you and me probably will be able to sort of quickly understand this is KMA and T, but people who have visuospatial problems are extremely challenging to find these letters. And then putting a face of a clock and marking a particular time also quite impaired in people with visuospatial abilities. Now, these problems commonly seen in people who have vascular dementias, perhaps who have hemianopias as well, but they are in the neurodegenerative other dementias like the posterior cortical atrophy, which is an Alzheimer's dementia variant. That is seen commonly in posterior cortical atrophy, where the patients complains of poor vision, and because of the poor vision, they go to an eye specialist, and the eye specialist probably check with the Stern chart and then the reading charts, and they probably find nothing. Perhaps or they might find a little bit of a tiny cataract. They try to do the surgery for the cataract, and then the patient still complaining of visuospatial problems. So the problem is not in the eyes, but the posterior cortex of the brain. So think about visuospatial problems when the patients are always complaining of the vision related problems, because if the eyes are not explaining all, you might have to think whether it could be due to the visuospatial problems in the brain. Then visual spatial problems also seen in people with dementia with Lewy bodies as well. We discussed the strokes and memory problems in the before. So those are the commonly tested cognitive domains, and understanding of these domains and how you are going. There are several other that we didn't discuss in the given talk, but if these are the ones which are commonly available in the batteries that you do. So if you know like the purpose, how to test this, and what particular domain that you are going to test by these cognitive assessments, then probably you'll be able to sort of say, like, in this patient's a cognitive assessment, these functions are deficit, and depend on the various components that the patient's having problems with, you'll be able to sort of find out what exactly the dementia diagnosis the patient is having, or that might sort of give you clue to a few differentials where the other investigations might be able to typify the dementia syndrome is. I hope that I try to make it more simple, and thank you very much.
Yeah, thank you, Dr. Manjula, for that detailed explanation on a not so easy topic on cognition and cognitive screening. So we've gone beyond our schedule, but just one quick question. Now, in the event where we do all these assessments where a patient administered component is required, are there any tools that we could use in our population? So, I mean, you mentioned a lot like MMSC, ACE, and MOCA. Out of all that, I mean, are there tools which could be used in our population, which have been validated for our population?
Absolutely, Kumarangi. Now, if you, the MOCA, Edinburgh Cognitive Scale and Examination revised, and MMSC all validated in single as well. But unfortunately, the MMSC is a copyrighted version. You need to purchase it if you use it for research purpose. So ACE3 and MOCA are validated in singular, which is appropriate for our culture, because the images which is shown for the semantic memory are not commonly appropriate for our culture. So they are validated tests. Absolutely, yes.
Thank you so much. So with that, let's move on to the last topic for this neurology update. So it's going to be on neurological manifestations of COVID-19. We have Dr. Sajita Veerasinghe, who's a consultant neurologist attached to Teaching Hospital Peradeniya, to deliver the talk on neurological manifestations of COVID-19. Over to you, Sajita.
Thank you, Kumarangi. Right, I hope my screen is shared now.
Yes, we can see Sajita.
Right. Today we are going to discuss about the neurological manifestations of COVID-19. So first, I would like to thank College of Physicians and ASN for giving me this wonderful opportunity. Right. So why do we talk about COVID-19 and the neurological manifestations? Is that even though the neurological manifestations are seen in the severe disease, when you take the magnitude and the extent of the pandemic, we have been seeing a lot of patients with different neurological complications all the time. And as you know, there are a lot of patients with chronic neurological illnesses, and also there are patients with who are on immune modulating or the immune suppressive therapy. So these patients are at risk of COVID-19 and also some of its complications. So over the next 20 minutes, I'm planning to discuss about the neurological manifestations of COVID-19, and touch a little bit about the pathogenesis of the condition, and then talk about a couple of common neurological manifestations and the management of those two conditions. So if you look at the statistics, about 2/3 of patients who are admitted with COVID-19, so these are the patients who had severe disease, demonstrated neurological manifestations. So some of them were mild manifestations like headache or the anosmia, but some of the patients had severe manifestations of COVID-19 related neurological complications. So how is the nervous system is affected? So one mechanism is by the direct invasion of the nervous system. But that is not the common reason why the nervous system is affected. So commonly it is due to immune-mediated mechanisms, so which could be either para-infectious or the post-infectious processes. Now, the para-infectious is when the patient is having ongoing viremia. So that is usually the first week or two of the illness, patient develops neurological manifestations. The post-infection is when the viremia has settled. So the acute infection has settled, and now the patient develops a immune-mediated complications. Usually that is 2 to 3 weeks following the viremia. And then comes the neurological complications, which are due to the systemic effects of COVID-19. Well, the neurological manifestations could be in all parts of the nervous system. So in the central nervous system, it could be strokes, which could be acute ischemic strokes, intraocular hemorrhages, venous sinus thrombosis, then encephalopathy, meningitis, encephalitis, myelitis, acute disseminated encephalomyelitis, all these hemorrhagic variants, and the CNS vasculitis, which is actually rare. And the peripheral nerve system could be Guillain-Barré syndrome or its variants, or the other neuropathies such as mononeuritis multiplex, and the skeletal muscles can be affected in rhabdomyolysis or the myositis. And the list goes on with many complications. So when you talk about the neuropathogenesis, the autopsy studies has looked into how the nervous system is affected, especially how the central nervous system, especially the brain, how it is affected. So it's mainly due to the neurological dysfunction from the systemic disease due to COVID-19. So it's mainly due to hypoxemia with the lung failure of the respiratory function, or due to the metabolic derangement due to the organ failure, such as renal failure or the liver failure. So in some of the studies where they looked into the brains of these patients by the MRI scans, and they found that the features are more non-specific or due to the hypoxemic brain injuries rather than specific pathological pattern. Now, I previously mentioned that the nervous system can be affected due to the direct invasion of the virus. So there were some autopsy studies, they looked into the brains and see, is direct invasion common in COVID-19? Now, if you look at these the histological pictures, if you look at the ones on the far left corner, they're the brain specimen. So they looked in the brain and they tried to probe and they tried to stain it for the virus. And fascinatingly, they could not find any of the viruses in the brain. But the same patient, when they looked at the lungs, they found large number of viruses. And also, if you look at the picture on the right side, so they did the PCR on these patients, different swabs, or they took different specimens from different parts of the nerve system and also in the respiratory tract, and they found there are a large number of viruses found in the nasopharyngeal or the nasal epithelium. But when they go more deep, they couldn't find much viruses in the brain. But when they looked into the vasculation, the one that is shown here in the bottom right picture, they found even in the blood vessels in the brain, they found the viruses. So they could not show much viruses in the brain matter itself, but they found viruses elsewhere and also in parts of the vasculature. So that means the COVID-19 virus is not a very neurotrophic virus. Okay. So how does the nervous system affect it? So it's mainly due to the vascular dysfunction or the immune-mediated disease. So vascular dysfunction is due to the damage of the endothelial function. So there is one mechanism is the renin-angiotensin system dysfunction, where the virus can enter into the cells, the vascular endothelial cells via the ACE2 receptors. So once they enter into the cells, they cause mitochondrial dysfunction and also endothelial nitric oxide synthase dysfunction. So that result in the vascular endothelium. That's one mechanism. The other mechanism, or one of the main mechanisms, is the immune dysfunction. So the disease causes a pro-inflammatory state. So there's a high levels of circulating cytokines, which affects basically all organs in the body. So if you look at the brain, there will be mitochondrial activation, and this is inflammatory response that causes the nervous dysfunction. And then the thrombophilic state, which causes the thrombotic microvascular injury, and the endotheliitis, which I showed you previously, the endothelial injury due to the viral infection. Right. So what are the common neurological manifestations that we come across? So one of the main reasons why neurologists start to see these patients is now patient's lungs are getting better, but my patient is not waking up. So it's one of the commonest calls that we get from the ICUs, why the patient is not waking up. So if you look at these patients, the encephalopathy is seen in about 1/3 of patients with severe COVID, and the delirium seen over half of the patients. And the risk factors being increasing age, being a male, and the non-communicable disorders, diseases such as hypertension or diabetes, and then the smoking. So these are the patients more prone to get encephalopathy. So when they look at these patients, most of the time they had low GCS, delirium, agitation, drowsiness, or sometimes seizures as well. And there were no evidence in the brain inflammation in these patients. And the neuroimaging studies were also non-specific. So they showed acute ischemic strokes, or they have a white matter lesions, as I showed you previously in those MRI scans, or a bit of leptomeningeal enhancement, or rarely encephalitis. And the CNS analysis was also largely normal in these patients, and only few studies showed the positive viruses. That also about 6% of patients had the positive virus. So the frank encephalitis is rare in COVID-19, whereas encephalopathy is common. And EEG was also non-specific, just showing the slowing of the waves, or rarely some non-convulsive seizure patterns. So the things we should consider if a patient is not waking up following COVID is a patient having encephalopathy. Then you think of the possibility of metabolic or septic encephalopathy, or the medication effects. Sometimes patient may be on drugs that are given to sedate the patient or to control the agitation, or cerebrovascular disorders, especially if they have strokes or lacunar strokes in the thalamic areas, which can give rise to low GCS. Rarely it would be non-convulsive seizures. So what are the things that are important for management is look for the contributory causes and correct them, and give supportive care for these patients, and they will slowly recover. And there's not much of place for steroids or minimodal treatment, even though that has been mentioned in some of the anecdotal reports, but it's not proven to be effective in patients with encephalopathy. So what about the prognosis? So the encephalopathy following COVID-19 is a poor prognostic factor, and it increases the morbidity. So the patient's hospital stay is going to be longer, and there's worse functional impairment at hospital discharge, and also increases the hospital mortality at 30 days. And when the patient is having severe COVID-19, even the recovery of the encephalopathy also going to take longer time. Right. The second thing I would like to stress here is the COVID-19 related strokes. The incidents are checked in the hospitalized patients, and these figures are from the US and the European studies. The ischemic stroke risk is about 4.4 to 2.7%, and the hemorrhagic strokes 0.2 to 0.9%, and the venous sinus thrombosis is about 0.08%. So, but there's one study, a Chinese study published earlier before these three studies, the two studies actually, but that showed a percentage of about 6%. But the study population was smaller, so we don't think the real number is not 6%, it's probably less than that. So we think it's about 3%. And the risk vary according to the severity of the COVID-19. So if the patient has milder COVID-19, the risk of getting seizures is less than 1%. But when the patient in the ICU, when the patient the other complications of COVID-19, like the respiratory failure, liver failure, then the stroke risk goes up to about 6%. The median age was about 65%, and there were some patients, the reports showing that the younger patients were associated with the COVID-19 related strokes. So what are the risk factors that are noted in the literature? So old age is one of the main risk factors, and the other vascular risk factors, which is seen in the patients who are not having COVID, are also seen in the patients with COVID-19 as well, like hypertension, dyslipidemia, diabetes, atrial fibrillation, the smoking. Well, is COVID-19 per se a risk factor? Well, when the people looked into the COVID-19 related strokes, they found COVID-19 is a risk factor for stroke. Even the patient does have other risk factors. So how does this happen? Now, this is a study published in 2011. So this is for 10 years before the COVID-19, 8 years before the COVID-19 the pandemic. So when they looked into the patients who had severe infections, when they have admitted to the hospital, infection and sepsis, and those patients seem to have increased risk of stroke. So that was published in this cardiovascular health study. So the mechanism is when they have inflammation, that increases the risk of getting thrombosis. So is this true with COVID-19? Well, when the researchers looked at the COVID-19, when they compared it with influenza, they found the patients with COVID-19 have a higher chance of getting strokes compared to the patients with influenza. So the COVID-19 is a risk factor for stroke. So if it's a risk factor, so how is this going to happen? So there are a few postulated mechanisms. One is a hypercoagulability and the pro-inflammatory state of COVID-19. And then the cardioembolism and the coagulopathy due to the disease or the treatment related, and the cryptogenic strokes. And I'll touch a little bit on the COVID-19 vaccine related strokes as well. Right, so what about the hypercoagulability and the pro-inflammatory states? Now, that is the interaction between the virus, the virulence of the virus, and the positive immune response that would result in the thrombophilic state in these patients. So there's elevated markers of inflammation and the hypercoagulability. So if you can check the fibrinogen and the D dimers, those levels will be increased in these patients. And then comes the cardioembolism, that is due to the cardiac dysfunction, which could be COVID-related myocarditis, or the COVID-related arrhythmias, heart failure, the MI that would predispose for neurothrombi, which later could shoot up and cause strokes. And then the coagulopathy and the anticoagulation. So actually, even though the ICHs reported, they were mainly due to the hemorrhagic transmission of the ischemic stroke. So actually, ICH risk is far less than the ischemic stroke, that is less than 1%. Right, and as I told you previously, there were reported cryptogenic strokes in these patients. So in some studies, it was what 2/3 of patients were categorized as cryptogenic. So it may be that the evaluation of this patient, the patients were incomplete, or there were atypical or the null mechanisms which we don't know to put this patient into a particular category or put a label and say this is the reason why the patient is having a stroke. Right, so how will we treat these patients? So the patient's evaluation and the treatment should be given as a patient who doesn't have stroke. So the IV thrombolysis with the RTPA can be given as a patient who's not having stroke. And there were no trials on the use of IV thrombolytics, but the anecdotal data do not show any safety concerns in patients who are having COVID-19 with strokes. And the mechanical thrombectomy can also be done in these patients, but only the important point would be the isolation and the control of the spread of the infection. There's some reports suggest that there's an increased recurrence of strokes that is probably the reocclusion of the vessels due to the hypercoagulable state. And also to make things a little worse, the COVID-19 related strokes seems to be multi-territorial, not just one territory. So the patients did have worse outcome in these conditions. So these are the patients who are not complicated with severe COVID. So if you're patient with severe COVID and the systemic dysfunction with the multi-organ failure, then the treatment for the stroke, that is whether to give thrombolysis or go for mechanical thrombectomy, that has to be taken case by case. The anticoagulation therapy can be given as if they're not having COVID for common risk factors for the cardioembolic strokes like atrial fibrillation or the severe heart failure. But you need to think of the bleeding risk and also especially if they're having organ dysfunction. Right, what about the COVID-19 vaccination? So the vaccine-induced thrombocytosis with thrombosis, the VITT. So that's seen in 2 vaccines, which I mentioned here, and that's due to the IgG antibodies, which bind the platelet factor 4 and causes the platelets much more sticky and causes the thrombotic state. Usually that's seen 5 to 30 days following the vaccination, and these patients are managed in acute stage with the intravenous immunoglobulins and also non-heparin-based anticoagulation, because the mechanism is somewhat similar to the heat or the heparin-induced thrombocytopenia. So we can't give heparin or enoxaparin for these patients. Right. So there was some concern when the vaccination started. Should we give a vaccine for these patients, or they're thinking of the risk of stroke? But when the studies looked to the patients who had vaccines, or if they don't give vaccine, what will happen? So what is shown in the purple color bars is the risk of the thrombotic events without the vaccine, or with the disease, not the vaccine, I mean, with the disease. So that is much higher compared to the risk of the vaccine. So what is suggested by the Stroke Association of UK is benefit of vaccine outweigh the risk of stroke, even the patient who had strokes in the past. That's one of the take-home messages from the talk. So what are the second prevention? So that's going to be same as other patients. So the management risk factors like hypertension, diabetes, dyslipidemia, AF, and the smoking, they can be put on aspirin or clopidogrel. And there are some concerns about giving ACE inhibitors or the angiotensin II receptor blockers in these patients because the virus gained into the cells by angiotensin II receptor, but it was not proven in the studies. Therefore, we can continue ACE inhibitors or the angiotensin II receptor blockers in our patients. As I mentioned previously, these patients can have multi-territory infarctions. So the strokes seem to be more severe compared to patients who are not positive for COVID. That is seen in a couple of registers, the US and the UK studies. Therefore, these patients have an increased mortality and morbidity and the disability. Just a few other complications of COVID-19. One is the neuromuscular disorders, Guillain-Barré syndrome, which we manage as if other patients, and the neuropathies, which could be focal or multifocal neuropathies. Or if the patient has been on the ICU for a longer period or steroids, we can get critical illness neuropathies or the myopathies. So the management is going to be supportive for these patients, and the Guillain-Barré can be treated with intravenous immunoglobulin or plasma exchange. The viral encephalitis is rare in COVID-19. Even autoimmune encephalitis is reported, but those are rare. So they are managed with steroids or therapeutic plasma exchange or the intravenous immunoglobulins. ADEM, or the acute disseminated encephalomyelitis, or its hemorrhagic variant of the hemorrhagic necrotizing encephalopathy, that is also managed with steroids, IVIG, or the therapeutic plasma exchanges. Just a slide about the long COVID syndrome. So long COVID seen is in patients who had COVID-19, and usually after about 4 weeks following the acute infection. Maybe it may vary from 1 to 3 months following infection. And it's seen in patients who have severe disease, or even a patient who had a milder disease, shows the persistence of the long haul COVID. So most of the patient would come with fatigue, the muscle weakness, dyspnea, they have sleep difficulties, anxiety, depression, like fibromyalgic kind of presentation. So they can have a very wide variety of symptoms, which is not particularly into a particular system or organ, which you can point to. And we are not quite sure why the pathogenesis, how it's happening. There are a lot of interesting mechanisms, though I think I don't have enough time to explain those. However, recent studies published in Nature recently showed that there are some structural changes, especially the connecting pathways in the brain affected in these patients. Right. Finally, the vaccine-related complications. So, now the vaccine is being I think most of us had 3 or 4 vaccines altogether, doses altogether. So these are the some of the side effects, central nervous system related side effects reported. And sometimes it's very difficult to point and say this is exactly due to the virus, or the vaccine. So there are central nervous system manifestations like venous sinus thrombosis, strokes, and ADEM, or there are transverse myelitis reported. There's some olfactory dysfunction, optic neuritis, Guillain-Barré syndrome, Bell's palsies, and the myositis. So there are a lot of complications that has been reported following the COVID-19 vaccine. So in summary, COVID-19 affect the nervous system, central, peripheral, or skeletal muscles. So we talked about 2 important complications, that is encephalopathy, being the commonest, and followed by strokes and few vaccine-related neurological complications. Right, thank you. I think I managed to keep in the time.
Yes, Sajita. Thank you very much for that detailed account on neurological manifestations of COVID-19. Altogether, in the interest of the time, just one single question for you, Sajita. How common do you find headache as a complaint in post-COVID? And is there a different approach that you consider in managing these patients?
I think most of the patients' symptoms were, well, yeah, we see a lot of patients with headache following the COVID or COVID vaccination. And most of the headache symptoms that I saw were more like tension type headaches, just not like typical migraines. And they were managed with amitriptyline, and I think most of the patients responded well to amitriptyline. Yeah. When having severe headache, I tried a bit of steroids like acute migraine, and they respond well to that as well.
So thank you very much. And so that's all we've lined up for today's neurology update. So on behalf of the Association of Sri Lankan Neurologists, let me once again thank CCP for inviting us to coordinate and deliver these talks. Thank you again, and let me hand over to Dr. Madhuwanti for the concluding remarks.
Thank you, Kumarangi. On behalf of Ceylon College of Physicians, I would like to thank our 4 speakers who has presented the excellent talks on current clinical practice in neurology. I'm sure our trainees especially have gathered so much of information to enhance their knowledge. Let me extend my gratitude to Dr. Darshana Sirisena, Dr. Kishara Gunaratne, Dr. Manjula Kaldera, and Dr. Sajita Veerasinghe for sharing their clinical expertise with us amidst their busy schedules. Letter of appreciation and certificates for the resource persons will be posted in due course. Thank you very much for your participation. Have a good, pleasant evening. Thank you.